I will go ahead and turn this over to UNM Health System Senior Vice President for Clinical Affairs, Dr. Michael Richards.
Good morning, everyone. I'm really pleased to be here with my colleague, Dr. Jason Mitchell, to have this conversation with you. UNM and Presbyterian, along with the other health systems in the state, have been facing unprecedented challenges as we've responded to the COVID pandemic and the impact in New Mexico. For over a year, we've collaborated and built systems that have allowed us to increase our hospital capacity and to manage these volumes. We've used contingency care techniques. We've collaborated to build things such as a statewide call center. But this event has lasted a very long time, and the scale of this has gotten to the point where we're now having to go to the next step of our overall statewide response. Currently at UNM today, we're operating at about 140% of our normal operating capacity and have had moments where we've approached 150%. This really is an unsustainable and unprecedented level of activity that we've been able to create. And as a recognition of where we are in the current COVID response, UNM and along with Presbyterian are declaring that we are in the position to activate the crisis standards of care in accordance with the public health order that was issued on October 25th. We'll be able to talk a little bit today about what that means. This will essentially allow us to focus on the most essential services in accordance with that public health order to ensure that the patients of New Mexico that need the care most will receive the care during this time of unprecedented volume. And with that, I'll turn this over to Dr. Mitchell.
Thanks, Mike. I'm glad to do this with you. It's good to have good partners in this. I want to talk a little bit about what we've done up to this point. This is not really a switch, it's a continuum, and I want to share with you all what we've done. One of the things we've really focused on is moving infusion treatment for COVID to the ambulatory setting, to outpatient, so that we give people the necessary infusions that keep them from getting sick. That's been a really key component of keeping people out of the hospital. We've also continued to postpone non-medically necessary surgeries to make sure that our hospitals have capabilities for those people that are acutely ill. And we've flexed a variety of spaces across our system, places you don't normally have patients, but we've been able to safely care for them there. So it's allowed us to continue to accommodate more and more options. Along with that, we've focused on people. Right now, Press has brought in over 300 traveling nurses to help us take care of New Mexicans. And that workforce is critical, and we're so thankful to have brought them in and augmented with that workforce. At the same time, we recognize we're asking more of our staff, and we've made sure to include additional incentives. So for those clinicians, those nurses, those respiratory therapists that want to work extra and are comfortable and willing to work extra, we're incenting them and rewarding them for doing so to acknowledge what they're going through. So we've really focused both on a facilities standpoint, moving things out of the hospital, and also on the people, building up more people and supporting those people through it. And it's been really, really critical to get us to this point and take care of people safely like we have been. I do also want to talk a little bit about, what does this mean for our patients? And this is across the entire state. When I say our, I mean our cumulative patients, and the help we need from you. I think it's just important to recognize that our EDs and hospitals are packed. And if you have less emergent needs, there's going to be long wait times. And no one likes that. It hurts our nurses, it hurts our doctors. We hate seeing that, and we know it's hard for patients. But just recognize that for the less emergent needs, there will be longer wait times. Along the same lines, to help prevent that, if someone doesn't have a true emergency need, remember there's a lot of great urgent cares across the state that can deal with a lot of those needs. So think about those urgent cares and utilize those urgent cares for the less emergent needs. There's also online care. We've got a whole system called Get Care Today, where oftentimes you can complete a whole digital visit in less than 10 minutes and get a large number of issues dealt with. So make sure you use that, or message your doctor if you have basic needs. So be thinking about how each person can contribute to drop the volumes in the hospital. And at the same time, we want to encourage you to get care. The worst thing is for someone to need to treat a chronic illness or an acute illness and avoid care, because then you get sick and get into the hospital. We want to take care of that up front. So if you have heart problems, diabetes, any other medical lung problems, don't wait to get that care. Call your PCP and get your medications refilled. Come in and see us. Come in and see your specialist. We want to take care of you today. Don't postpone that, because postponing that is one of the things that's led to the crisis in our hospitals. So I wanted to share a little bit about what we've done to get us to this point safely, and then a little bit about the expectations of what patients can expect and how you can help us as well. And Mike, I'll hand it back to you. I think you want to talk a little bit also about what we can ask from our community to help us.
Great, thanks, Jason. Again, I really want to emphasize the point that, we're going to continue to deliver care. This recognition of where we're at in the delivery system allows us to take our response to the next level and ensure that we're prioritizing those patients that need the care the most. And for those that can and have some postponement of things that are non-essential, though that will create some additional capacity, but we want to absolutely make sure that those individuals who need care get the care and that they need. And so as Jason pointed out, there are other things that we can ask the community to do to help us. This pandemic is not over. And we really need everyone to think about, the role that they can play by continuing to exercise the public health measures that gave us such great success at the beginning of this, which is the wearing of the mask and washing your hands and avoiding large crowds. Those things are just as essential today as they were at the beginning of the pandemic. And then the single most important thing that we really want to encourage everyone to do is to get vaccinated. It is, we're in flu season, and I know that some folks have been really good about getting their flu vaccine, but we also need to make sure that you're getting your COVID vaccine, and when appropriate, getting the COVID booster vaccine. Absolutely essential to this. And as part of that, we believe that getting children vaccinated is also a critical part of our public response, and that we want to make sure that is also happening. And so those are the things that can help us bring down the spread of the disease, decrease the likelihood that if you do get COVID, that you'll need hospitalization, or that if you do need hospitalization, that you'll have a bad outcome or need an ICU. All of those things will help us, manage this with the contingency care and the extra capacity that we've developed.
Thank you, Dr. Richards. Thank you, Dr. Mitchell. Next, we'll go ahead and open it up for questions. If you have a question, let me know in the chat and I'll call on you. And we'll just ask that everyone ask one question and a follow-up. And to make sure we get everybody's question in, we'll go back after everyone is able to ask a question, then we can go back if you have another question.
Hey everyone.
Jesus, do you have a question?
Yes.
Yeah, go ahead, Jesus.
For some reasons, I don't see your screen anymore. Let me see. All right. My question for you guys is, how are you going to make sure to get the response to the next level? And why you guys didn't do that before? What is new for the people to know about what you guys gonna do to decrease or diminish the COVID infection level at the community?
Well, Jesus, I'll start off. And so the first thing I want to just make sure that everyone knows is that, again, to re-echo some of the things that Jason pointed out, we've built an unprecedented level of extra capacity within our delivery systems now. As Jason pointed out, that meant, creating hospital beds in atypical spaces. That's part of our contingency care. All of us building additional workforce by either reallocating individuals to jobs that from their normal jobs to jobs of helping manage the extra volume, and then bringing in a significant number of outside individuals, medical experts to take care of patients. Jason talked about the nurses at Presbyterian. We've also done that at UNM. We have over 500 additional nurses that we brought into the system, which has allowed us to stand up over 100 additional hospital beds. And so that's a tremendous community response. Also, as part of this, we've been working very collaboratively as a state and as health systems to share the resources and best practices, and to also, share information. And one of the best examples of that work is the day-to-day activity that occurs through the medical advisory team that is still ongoing, or the data and analytics that have been supported by Presbyterian, or the call transfer center that UNM is operating at this moment on behalf of the state of New Mexico. And Presbyterian operated that earlier in the pandemic response. All of those things demonstrate a level of really unprecedented collaboration, both for us and quite frankly, a national best practice model in many areas for building capacity. So we've done a tremendous amount in that area. What we're really doing today is recognizing and labeling this that appropriately, because we are at the place right now where the contingency levels of care that we've built have been stressed to the point where we are delivering things under the crisis standards of care per the public health order. And so, as Jason mentioned, this isn't a significant change in trajectory on our response, but just recognition of the continuation of our response, that we've kind of crossed over into that threshold. And so what this really means for us is that the non-essential medical procedures, these are the things that can be delayed, that won't cause harm to a patient, and that is defined very clearly in the public health order, that we will start to implement those delays. And we will work very closely with our surgical experts and their teams to make the decisions on which of those patients can have their care delayed. We really recognize that care is essential, and we want to ensure that it gets done. But during this time where the hospitals are at this very high volume, if those things can be temporarily postponed, we will do that. But we also are very mindful that we don't want to see additional or bad outcomes occur because of delays in care. So we'll be very thoughtful about that. Other services, like our ambulatory services, are going to continue to function and be ramped up to the degree that they can deliver services, including both the in-person and the virtual care. So those are the things that we're going to do. So I would really think of this as a continuation of a very robust response, not a change of trajectory.
Yeah, and I think you guys mentioned that right now you are on the 100% of your capacity. Is that right?
Well, what we're reporting and the way that we're describing this is in relative to what our normal volumes in the hospitals would be. Okay, and so when we talk about numbers like being at 140%, what we're referring to is that we're at 140% of what our normal operating volumes would be. But we've created the capacity to safely take care of that 140%, but the ability to continue to grow that is limited by both physical space and the availability of healthcare professionals, which is why we have to really, try and manage the current capacity that we have to the best of our ability, which again requires us to focus on those essential services.
Yeah, I know you guys are mentioning that we need to go back to the first measures we take, wearing masks, avoiding large crowds, and get vaccinated. But actually, New Mexico have a high rate of vaccinated people. So how come we can explain to the people, oh, go get the vaccine, and still the case keep increasing?
Yeah, I'm happy to answer that question of why now. Why is such a good state in a point with so many cases? And there's a couple reasons for it. One of them, really to prevent a pandemic and prevent spread, you have to think about every New Mexican that's vulnerable, which is everyone from birth, to the very end of your life. If you look at that number, New Mexico has about 63% of our people vaccinated. So when you think of it that way, it's not enough to decrease the available folks for infection spread. There's still too much spread. The other thing we did really, really well is we vaccinated people very early in the pandemic, which was wonderful. We know that vaccines likely need boosters. In fact, there's lots of recommendations now for boosters. And so the vaccine immunity wanes, decreases over time. And so since we were early, we're seeing that waning vaccine effect and we need to do boosters. Other states were late to the game. And so in another few weeks or months, you'll see their vaccine, their immunity waning also and needing the boosters. And so really what we need to do at this point is we need to think broadly about every New Mexican and anyone that's eligible for a vaccine, which is everyone from 5 and up, has got to get vaccinated. So we have enough of us vaccinated, and everyone who's eligible for a booster, which is a large portion of us, make sure you get your booster at 6 months so that you don't have that waning immunity. There's nothing wrong with a vaccine. Many vaccines take 3 shots, right? When you think about your kids, you take them all the time to get their vaccines and they have a series of shots. COVID's no different. And so the booster is just part of building that immunity. So those are the 2 things we need to think about: the overall population, everyone that can get vaccinated. And if you're eligible for a booster, please get your booster. You need it to protect all of us.
Appreciate it.
Thank you, Jesus. Next, we will go to Ryan Botel of the Albuquerque Journal. After Ryan will be Chris McKee of CAREEME. Go ahead, Ryan.
Thanks, Mark, and thanks, doctors, for talking with us today. Can you give me an example of what a crisis standards of care decision that a physician would have to make, and kind of just describe what type of patient is going to be most affected by this declaration? Thank you.
You know, it's really important to recognize we are not deallocating care. That is not part of this. We are not triaging and denying care. At this point, we are trying to make sure that every patient has care in a bed across our state and even surrounding states. So the decision is not going to be to take someone off a vent. That's not what we're doing. The decision may be, we don't have beds in our hospitals. Who else can take this patient? And it may mean that a patient goes into a regional hospital that still has capacity. It may go to a different Albuquerque hospital. So the decision is, how can you get the patient to the best spot where there's an available bed? It also may mean that some patients have to go out of state and that we end up transferring patients to surrounding states like Texas, like Arizona, like Colorado, who oftentimes have a lot more hospital beds than we do, just fundamentally. As states. And so the decisions we're going to be making are, how do you get that patient to the best place for them to get care now? And even if it's not your own hospital, even if it's not UNM or Press. But again, it's not going to be taking away care.
Thanks, Ryan. Next, we'll go to Chris McKee at CAREEME. After Chris will be Stella Sun at KOAT. Go ahead, Chris.
All right. Thank you very much, Mark, and we appreciate your guys' time here today. I did want to ask about the process of sort of figuring out those non-medically necessary procedures that may be able to be postponed. I know hospitals do a lot of work projecting numbers out, but I'm also sort of hearing that you guys are beginning the process of maybe implementing those delays, so to speak, to the patients that may be able to take them. So I wanted to just ask, though, I imagine you guys maybe have a number or a forecast on maybe how many medically, non-medically necessary procedures can be postponed, or about how many patients would you sort of keep out of the system who maybe over the next few months have things scheduled out. Do you have a forecast or a number of how much this may be able to help numerically patient-wise? Thank you.
You know, it's really a great question. And the answer is different now than it was at the beginning of the pandemic. At the pandemic, there were lots of elective surgeries. And so we shut everything off and it created a lot of capacity. After, a year and a half in, and postponing surgeries, there's less and less non-medically necessary surgeries. And so, as we scrub our schedules, we may see across all of our hospitals that there may be 2 or 3 or 4. So it's not large numbers anymore. People have already put off their surgeries for a long time and they've become medically necessary. We do follow very well-defined criteria and have throughout the pandemic. We have a team of clinicians that meet every week, look ahead of the schedule and make sure everyone's meeting those criteria, and then make sure we flex where we have to. And so we will continue to follow that process. It is unfortunate, though, so many people have already had to wait for surgeries that now the vast majority are medically necessary. you just don't see that many that are left. So it will give some capacity, and I'm really happy about that. It's not as big of a lever, which is why we have to start focusing on other levers, like how do we stand up beds maybe at other hospitals. For us, we have our Caseman Hospital, where we may be able to add some additional beds and things like that. But we will continue to work on the surgeries.
And we have a very similar kind of expectation because the experience is the same. And so in our response plan, we have a tiered approach. And the level that we're implementing now is if a surgery can be postponed for 90 days and without having any impact on a patient. Now, if it becomes necessary, then we can move that to 60 days and then to 30 days as needed, but we're starting with that 90 days. And as Jason pointed out, these are, in most cases, I would frame this as that the care is all necessary. It really is a matter of deciding whether or not it has to be done today or whether it can be postponed. And if it can be postponed, then we can, get through this current peak and the high capacity level and then be able to do the surgery when there's more capability. But we're, again, are very thoughtful to ensure that this doesn't cause any harm to patients. And in the public health order, there are very clear definitions of what medical necessity is, and I encourage you to take a look at that. But we still use our medical experts, our surgeons, to evaluate this on a case-by-case basis.
Thanks, Chris. Next, we'll go to Stella Sun of KOAT. After Stella will be Jackie Kent of KRQE. Go ahead, Stella.
Thank you so much for taking my questions. For both of you guys doctors, I was just wondering, do you think another shutdown may help this? I know you guys have pointed to delayed care contributing to enacting the crisis standards of care, and you've also mentioned how vaccinations in the community may help, but it's clear that a lot of folks, just no matter what they do, will not get vaccinated. Maybe more vaccine mandates. What are your guys' thoughts for this?
Well, I want to go back to focusing on the things that we know work as the first steps. And so I know you're specifically asking about a shutdown, and I don't offer an opinion on that at the moment, but I do strongly believe that as individuals, we can exercise things that increase everyone's safety and increase your own personal safety. And that, again, that's the being diligent about the mask wearing and washing your hands and using appropriate social distancing. And as we've talked about, really emphasizing the importance of vaccines for everyone, 5 and up, and for those who are eligible to get the booster vaccines. So I really believe that those are the important things that we need to make sure that we encourage everyone to do at this moment. Thanks.
And I still believe there's a lot of room for vaccination. There are a small subset of people who will never get vaccinated, but there's still a lot of people that are ambivalent about it, and now's the time to get vaccinated. And so for those individuals that are not sure or put it off, that's a big group of people. And that can make that can make us or break us. The same thing with our kids. We've now got the 5 to 11. We also have the kids 12 and up. And so every child 5 and up can get vaccinated. That's a lot of people. That's a whole lot of New Mexicans, and that really changes the ability of COVID to spread. So I don't think we've run out of levers on vaccine. And I think if we can all pull in together and focus on that, it'll make a huge difference. And like Mike said, washing your hands, staying out of crowded places, wearing a mask consistently is really, really important. Probably the biggest thing about wearing a mask, and I've seen this happen, and I think it's because people don't necessarily know the science behind it, but waiting until someone walks in the room and putting it on, and when they walk out of the room, they take it off. That doesn't provide you protection because those little particles of virus hang out in that room for a while. And so the mask on and off isn't protecting them or you. You got to be consistent. So, again, I think there's things each of us can do, communities can do, getting together, at your church, at your school, in your social groups, and focusing on how to protect yourselves can make a big difference for us.
Thank you, Stella. Next, we'll go to Jackie Kent of KRQE, and after Jackie will be KOB. Go ahead, Jackie.
Thank you, Mark and doctors, for your time. You both mentioned how you have made extra capacity in your hospitals, how much of that is for ICU beds? Can you both touch on how overwhelmed your ICUs are? Are you looking to clear out even more wings to add more ICU beds? Also, how many patients in your ICUs have COVID and how many are non-COVID patients? Thank you.
I think, on the numbers, we can do some follow-up and provide some written numbers so you have a sense of what that is. Really, the biggest challenges we have, our ICU doctors and nurses and clinicians have just been amazing and seem to just, no matter what, make it through this. And I'm so impressed. Our big challenges are getting patients out of the hospital so patients can move in, right? So our EDs are packed because patients can't get up to the hospital because patients are so sick, and then we don't have a place to put them. So it really is the entire process that's straining the system. And the more we can get patients home as early as possible from a hospitalization, the more we can get patients into skilled nursing facilities and post-acute facilities. That's where we really have to offload the hospital. That allows us to get more patients in. And so at this point, it's not necessarily we don't have enough ventilators. It's that the overall demand in the hospital has exceeded the capacity, and the demand on where patients go after the hospital has exceeded capacity. And that's where our focus needs to be. All that said, our ICU clinicians just work hard 24/7 and never seem to run out of steam. And we're all in for them.
Yeah, and I agree with those comments. We've built additional ICU capacity, and there continues to be stress on the ICUs. But the other place where the hospitals are really expressing a significant level of stress is actually on the non-ICU patients. And so that is a little bit different than, say, earlier conversations we had around the pandemic, where the main concern was on just ICU beds and whether we would have ventilators. We've really built capacity there. It's really on just overall general hospital capacity. And clearly COVID is a very big driver of it, but then there's also non-COVID volume that's still essential that we take care of, that is also a part of that hospital capacity. And as Jason pointed out, the hospitals live in a system of care. And so so it's also being able to get patients out of the hospital and into the next level of care, whether that's skilled nursing or home level care. All of those elements are really full and saturated at the moment. And so it's really across the system. The thing that I worry and I'm most concerned about for the ICU is that it's not whether or not we create the ICU capacity for the COVID patient, but it's that we need the ICUs for other kinds of patients also. So the community needs that we have for trauma patients or patients that might have a heart attack or a stroke that need an ICU, we need to ensure that that capacity is there for them too. And so, so that's part of why we talk about this as all of the patients and all of the hospital volume.
Thanks, Jackie. Next, we'll go to KOB, and then after KOB will be Susan Montoya Bryan of the Associated Press. KOB does not have access to a microphone, so I will ask the question on their behalf. Obviously, we're seeing more COVID patients, but are there other contributing factors? And they're also asking, although you're bringing in travel nurses, do you guys still need staff?
So yes, the COVID numbers continue to go up, and we're actually seeing more hospitalizations for COVID. So that is trending up, and it's very concerning. Additionally, we see all illnesses trending up, and we've seen that since, for the last year. Our volumes have just been much higher with really acutely ill patients for all reasons, whether it's a blood infection, whether it's a lung problem, a heart problem. Everything's been exacerbated, I think, because people delayed care. And I know why they declared care is because people were afraid to come in and didn't feel like they could come in. And so we need people to come in and get your care early and not delay that care. I think that's really contributed to it. With regards to more staff, yes, our state still needs more staff. And we work very closely with Secretary David Scrace and with the governor's office, and they help coordinate bringing in external resources as well. We need those resources, especially in hospitals that have open space where they don't have enough staff. We need it there. And then in our organizations, we continue to bring in additional staff.
And one of the real challenges that we face on staffing is that in other kinds of disasters, which are more geographically isolated, then you are able to tap into the healthcare workforces in areas that aren't affected by the disaster. But in this case, this is a worldwide event. And for at least us in this country, you know, the entire country is facing this, you know, this increased need for healthcare services. And so we've really gotten to the place where it is more difficult to bring in outside staff to help build more capacity, because there's a lot of competition for that staff, and that they're needed everywhere. And so there's not a geographical place that's been so spared with this that they've got extra people that could be reallocated. And so that's one of the reasons why we think about, you know, needing to actually really protect the capacity that we have right now, and ensuring that those essential services are delivered, because the ability to grow more is quite limited at this point.
Next, we'll go to Susan Montoya Bryan of the Associated Press. After Susan, we'll go back to Stella Son of KOAT. Go ahead, Susan.
Doctors, thank you for taking our calls this morning. One question, I was hoping you could expand a little bit on the demographics of the patients you're seeing. While it's obvious they're not all COVID, maybe you could give us a percentage of what you're looking at there. And then also, we talked early on in the pandemic about comorbidities or pre-existing conditions. So is that what you're seeing with this group of COVID patients now? Thank you.
Well, Dr. Mitchell kind of talked about it already, and we can get you specific numbers, but it is actually all patients that have gone up. It's and so when I look at our COVID numbers, you know, currently at the UNMHEALTH system, they represent about 70 patients today. You know, in the Presbyterian system, they're 120 to 130 today, because we share this information with each other as we're managing the resources across the state. And so, so as you can see, those are significant numbers of patients, but you know, we've built capacity much greater than those numbers. And so that represents the fact that there are other kinds of patients who are using some of this extra capacity. And it really is across the spectrum of healthcare. And it represents, you know, just a higher level and higher number of the same kind of patients that we were seeing, you know, before COVID. But oftentimes these patients are sicker because, as Jason pointed out, they may have delayed their care. And so they're requiring more intensive therapies when they're in the hospital, and sometimes staying longer. And then because we don't have as much out of hospital care to refer patients to, that sometimes creates some delay in moving patients into the next level of care, which also uses up the hospital capacity to some degree. So it really is an increase across the full spectrum of patients that we've talked about.
It's a really interesting. So about 20% of our patients are in-house because of COVID. And we were running about 120% of our normal capacity. We normally run, you know, very, very full anyway. So, but it's more than just additive. It's not like we just have that extra 20% of patients that are COVID positive. It's that the people that don't have COVID are also much sicker, and so they're staying longer. And so even at 120% capacity, things are worse because people need to stay longer because they're much sicker, and that backs the whole system up. So unfortunately, it's not a 1 + 1 = 2, it's a 1 + 1 = 3 when it comes to the impact on our clinicians and our patients and access.
We're very similar for us. We're at about 17% right now of the extra 17% are COVID patients, but we've built about 140% capacity. So that is an example of that. It is not just the COVID patients, but it's, you know, other kinds of patients who are needing hospital level care that are part of this high volume that we're experiencing.
And are comorbidities still playing a role in those COVID patients having to be hospitalized?
Yeah, so obviously, the more comorbidities you have, the more likely you are to get hospitalized, and the more likely you are to die. And so that's just the nature of the disease. That said, we've had plenty of younger, healthy people get hospitalized, and we've had younger, healthy people die. And it's just a tragedy. I was in our ICU a couple weeks ago, and we had an individual who is much younger than me, who was in there for quite some time, and everyone cared for and passed. And so this is not just for the vulnerable. It's just not for the elderly. It impacts every single individual. And we are seeing that even in our hospitalizations, the number of people that are younger or hospitalized has gone up significantly from what it used to be, primarily because you've got your 65 years and up that have been vaccinated. And so we're seeing a lot of the unvaccinated people that are younger people coming in and getting hospitalized.
Thanks, Susan. Stella's question was just answered, so we'll go ahead and go to Chris McKee at KRQE, and then after Chris, we'll go back to KOB. Go ahead, Chris.
Sure. Thank you guys again. I wanted to ask a question in relation to staff. You had both mentioned as well that the numbers are just sort of I guess the number of staff is maybe lesser than, or perhaps I should say, I know Dr. Grace has mentioned on a level that there are fewer healthcare workers right now than perhaps there were at the same time last year. So along those lines, if you guys just maybe compare your health systems one to the other year over year, are you down staff significantly? Are you around the same numbers? Is it like, 40% fewer staff at this point than we had last year? Do you perhaps have a number that maybe could help us gauge just sort of what the gap is compared to how many people were available last year?
So I think that statement really is maybe very reflective of some of the experiences that rural hospitals are having, because I think that there are clearly staffing challenges. But what I can say is that that our staffing levels are actually up because we've added an additional 500 individuals, and we've also reallocated individuals to do different kinds of work. So when we talk about the staffing challenges that we have right now, they really are in recognition of the fact that there's not additional staff to tap into to continue to grow additional capacity. And that we recognize that in some areas where they haven't been able to completely staff up their beds, that there might be hospitals around that have more beds than they have available staff. And the difficulty now is that as we talked about, that this response is national wide, and so there's not a remaining pool of additional nurses or other medical staff to really tap into, because everyone has done that. And so that's part of the staffing shortage that individuals are talking about.
Thanks, Chris. And the next question comes from KOB. State officials mentioned an increase in vaccinated COVID hospitalizations. Can you talk about the differences in care once hospitalized? Are there differences between caring for a vaccinated COVID patient versus non-vaccinated?
I think the biggest difference is the vaccinated people do a whole lot better. If you're vaccinated, you have a much lower chance of getting hospitalized. And if you get hospitalized and you're vaccinated, you have a very, very low chance of having a severe complication. And so the biggest difference is they do better and they go home quicker.
Does anybody else have a question before we bring today's media availability to a close? Seeing none. Okay, thanks everybody for joining us again today. If you need a copy of this recording, please let me know. And once again, it's also on our Facebook page, which is UNM Health Sciences. Thanks, everyone.
Take care, you all. Thank you so much.
Thank you, everyone.